We are now moving into the Medical Cardiac Arrest Directive. This protocol governs the management of non-traumatic cardiac arrest for primary care paramedics. The indication for this directive is non-traumatic cardiac arrest. We must consider very early transport after a minimum of one analysis after an egress plan is organized in specific settings. If the patient is pregnant and presumed to be 20 weeks gestation or more, which we landmark by the fundus being at or above the umbilicus, or if there's a known reversible cause of the arrest that we cannot address in the field, such as hypovolemia, hypoxia, thrombosis, and toxins, just to name a few. If the patient is pregnant, remember to perform manual displacement of the uterus to the left to improve venous return as the fetus sits on the vena cava when they are supine. For manual, automated external defibrillation, or semi-automated external defibrillation, the patient must be 24 hours of age or older, in an altered state of consciousness, and presenting with a heart rate of 0 in a shockable rhythm like VF or pulseless VT. Epinephrine is indicated for patients 24 hours or older if anaphylaxis is suspected as the causative event. Additionally, for patients 18 and older, we also have conditions for advanced defibrillation if the arrest is of presumed cardiac origin and they have received 3 consecutive standard shocks. The medical termination of resuscitation can be considered for patients 16 years of age or older if 3 specific criteria are met. The arrest was not witnessed by a paramedic, there has been no ROSC after 20 minutes of resuscitation, and no defibrillation shocks were delivered at any point during the call. There are no listed contraindications for standard defibrillation or advanced techniques like DSED. However, epinephrine is contraindication if there is a known allergy or sensitivity to the drug. For the medical tour, contraindications include pregnancy over 20 weeks, suspected hypothermia, airway obstruction, or a non-opioid drug overdose or toxicological cause. Our manual defibrillation protocol is tiered by age. For patients between 24 hours and 8 years old, the initial dose is 2 joules per kilogram, with the subsequent dose at 4 joules per kilogram. For patients 8 years and older, doses are delivered according to the regional base hospital or manufacturer's specifications. In all cases, the dose interval is every 2 minutes. When using an AED or an SAED on patients under 8 years old, use a pediatric attenuator cable if available. For refractory VF or pulseless VT, defined as persistent after 3 consecutive shocks, patients 18 and older may receive 1 dose of DSED, double sequential external defibrillation, or vector change defibrillation every 2 minutes. We may provide up to 3 doses of DSED or VSED before initiating transport. If anaphylaxis is the suspected cause, we administer epinephrine concentration 1 to 1,000 via the IM route. The dose is 0.01 milligrams per kilogram, which may be rounded to the nearest 0.05 milligrams up to a maximum dose of 0.5 milligrams. Only 1 dose is permitted under this directive. You must patch to a base hospital physician to consider a medical tour. You can patch early if there are extenuating circumstances or if you consider ongoing resuscitation to be futile. If the patch fails or no ROSC occurs after 20 minutes, you must initiate transport. Finally, remember that a base hospital physician may deny a tour even if the rules are met. They will consider factors such as end-tidal CO2 levels, age, bystander, CPR, and unusual causes like electrocution, hanging, or toxicology. Regarding DSED, the second defibrillator should be a paramedic device or a fire service device if they agree. If a second unit is unavailable, you must provide vector change defibrillation instead.